Right. So this morning we're going to discuss indirect bonding. My name is Jeremy OYAHON, and the objective is to tell you about Indibond. I'm going to share my successes but also my failures, and so I'm going to share both my successes but also my failures. Before I start, I'd like to thank Charlie and Author Partner. It's the first time that I speak in public, so I'm a bit stressed, but I'm very grateful as well. I came across Author Partner when I was working in Luxembourg. I met with Ariel and we had a very good time together. So it all started with me meeting Ariel. But apparently the remote control is not working properly. There we go. So it all started like a journey. It started in a butchery. This is Frank's cousin that you can see here. We were at a congress. We were PhD students, and Frank's cousin is a butcher, and so we had a beautiful meal. And this is how the history started and the journey started. So very quickly, I'm an orthodontist specialized. I opened a practice 1.5 years ago, but I also work in Yverdon in Switzerland. There's nothing interesting to be done in Yverdon, so don't go there. However, I do have a practice there. What I'd like to do, we're going to talk about indirect bonding, we're going to talk about Indibond, but we're going to discuss a few clinical cases, and the most important thing I'd like to share with you are the failures that we've had, and I would like you to have a learning curve. So indirect bonding, historically, in the 60s, we started bonding that would be with epoxy resin, but epoxy resins would take ages to really bond. Then there was some indirect bonding by Silverman in the 70s. In the years 2000, we started using digital impression making. Till the early 2000s, we would do direct bonding, and then we started having stereolithography. We started using jigs to perform indirect bonding, and this is what we use today. Now, bonding, we start with a working model, then we position the brackets on the model, then we transfer in the jig, and then we bond. So 4 steps. In the last year, we've had a number of changes. First, we started with a physical model, either with silicone, or now we also use printed models, but currently we have an even more easy-to-use solution with a digital model. So the digital model is what we use with Indibond, and all the clinicians I know work with digital models. The transfer jig in the past was manufactured by a lab. It was manufactured manually. We would have opaque silicone trays. The problem is that we had self-curing resin, and that wasn't very convenient. Then we had Memosine and Imilumas, transparent silicone, and then the thermo created. And this is what we use in Indibond. I was trained in Strasbourg. The Hibolanda is the chief clinician, and he's very much evidence-based. So everything he does should be based on scientific knowledge. While I was a PhD student, I also was with the same mindset, evidence-based. But I also think that we need to strike the right compromise. Of course, we need to use evidences, scientific evidences, but then again in studies you may have biases, and on the other hand you can only be clinical based because there are some clinical cases when it works, but it's not going to be generalized to all clients or patients. So yeah, you need to strike the right balance, be evidence-based, but also clinical-based. First question that you need to ask yourself is to know whether the jigs are reliable. This is a systematic review dating back to 2023. If you're not familiar with those graphs, when the dark lozenge is superimposed with a line, it means that you have something that is accurate. But there are 2 areas when this is not very accurate, and this is in particular in the buccal lingual direction. So, generally speaking, our jigs are acceptable, clinically acceptable from an accuracy point of view. So there's a 0.5 to 1 millimeter offset. Now, what we are interested in is to know whether indirect bonding is quicker, less expensive, do we have more or less finish-ins, and do we need to rebond many or not many brackets. And I'm just going to go through 4 studies, and I will provide all literature at the end. Well, obviously, in the chair, it takes longer in preparatory steps. It's taking less time in the chair. When you bond and you remove the jig, sometimes some brackets just come off, and there are uncertainty as to the accuracy. Some studies concur that it's more accurate and others don't. So this is the evidence-based conclusions. So in studies, they say that you gain 3 minutes per arch. In my practice, indirect bonding is quicker. Overall, it takes more time, but then you can delegate some tasks. When you do indirect bonding, you can delegate some tasks. When you do direct bonding, you can't. So with the right quantity of resin, I do not have that many brackets coming off. Now I'm going to talk about Indibond. Indibond is the indirect bonding solution by Arthur Partner. I've been using this since 2022, and so far I have bonded 90 cases. I started in Switzerland. In Switzerland, I use either lingual brackets or the buccal brackets. Now, with experience, preparation takes 10 minutes and bonding takes 20 minutes for both arches. What are the advantages and drawbacks? First advantage, it's very accurate. It seems that I have less finishing and less repositioning of brackets. I find it very comfortable for myself and the patient. They do not have to open the mouth. They do not have we do not have to control saliva and the dryness of the operating field, and I find it very reproducible. Even when the patient has a small opening, mouth opening, you're going to have a very high quality bonding. Drawbacks, there's a rather sharp learning curve, and you do have to invest, and I'm going to discuss the costs that come with indirect bonding. I'm showing you the difference. What's in pink is what your assistants can do, and in blue what you do. So, for example, applying resin on the brackets can be performed by the assistant. It's going to take between 6 and 7 minutes. Bonding is going to take 35 to 40 minutes, and then the wire, it's going to take 2 minutes for me to insert the wire. Now, this is on the left-hand side. This is conventional bonding. Indirect bonding, you have a number of steps that you can transfer to your assistant. So yes, I double the time that my assistant is going to use, but then obviously the time of your assistant is not worth the same amount of money as yours. If you look at the cases, conventional system, with a conventional bonding, you're going to spend 45 minutes at the chair. In direct bonding, the material costs just the same, but you need also to add the cost of the jigs. For insertion, either you ask the partner to insert the brackets in the jig, or you do it yourself, or your assistant. So less time at the chair, but increased time of your assistant. But it's not too bad, because the assistant's time is less expensive. So in green, it's where you save money or time, because you just have the patient for a shorter period of time in a chair. I'm going to show you the time flip. Time flip is like this sort of device. There's also a stopwatch, and I use that to really assess how long it takes to bond. And you can also see the progress that you have. Oh, that's Netflix. I was not supposed to do that. Thanks to indirect bonding, you have more time to enjoy Netflix. No, joke aside, this was not planned. It's a cauchemar. Yeah, Arcade is a wonderful series that I do recommend on Netflix. So Time Flip is this device. It's only 60 euros, and I find it very useful to control how much time you use. Tu vois là, je capte plus rien. Ça c'est coupé, mais je m'en fous, j'entends tout ça. So you send your case, you receive a setup, and then you have two c'est revenu. And then you have two options. Julien, ça arrête pas de couper. Julien is in charge of that. If you print in the so either you use a lab in-house or you send it to off a partner and they do it for you. Ça coupe pas. Comment? Ça arrête pas de couper. Alors il n'y a plus le grésillement mais ça plaît. Et là j'entends la musique ici, j'entends toutes les conversations, c'est effroyable. Effroyable. So you send the case, you have this form, it's very time efficient, you have a few things that you have to fill in. You check whether you want to bond on both arches or not, and setup. So this is my protocol whereby I validate my setup. I'm not saying it's the best, but it's the one which works well in my hands. So you need to respect those different steps, because if you change them, it's obviously going to have an impact. You need to work on first orders, then on tips. So this is what we do. And again, it's about 10 minutes worth of your time, and you can delegate that to your assistant. First step is the distance between the bracket and the tooth. When you start, the brackets are just too far away from the tooth, and so you should go tooth by tooth. See, it's too much of a distance, and so all my brackets would come unbonded. So your first step is to bring the brackets closer to the tooth. Tipping is very difficult to control. AI in the platform does many errors. The central line, the different lines are really not accurate. So you need to validate tipping, and then I will show you in a minute how you can make this more accurate. I just changed the bracket to make the whole thing more accurate. So when I started, I would change the tooth and not the bracket, but I'm under the impression that when you change the position of the tooth, it doesn't quite register in the bracket. Anyway, for first order, it's very easy, so very easy to control any first order movements, and this is vertical dimension. So you have tables, as you can see, and manually you can change those values. For those using PITS protocol with smile arch protection, you can apply PITS protocol. We shall talk about this. I don't really use it very often because I don't trust the platform 100%. I check everything. I check the different rotations and vertical dimension. Very quickly, I'm going to show you the different features. The platform comes with many features, some of which are very useful and others are less useful. You can add ramps, and you can integrate those ramps naturally. I don't really use it because I don't like the shape of the ramp. They also have bite turbos, and they can be very useful, but one of the improvements is to have anatomical ramps that are really going to be designed to match the shape of the cuspids. Then you have contacts in between brackets. This is very useful. When it turns red, it's because your brackets are colliding. Tracings is a feature that I don't really use. It's just to check where you have your gingival contour or when you have the crust. And I really don't like to display those because I don't find them very accurate. This is a feature which is very useful. Superimposition. You can superimpose your digital impression with CBCT, and then you can check how thick the cortical bone is, for example, and you have the superimposition before and after. This is a class 2 on the right. You see that we were able to visualize by 10 millimeters, so this is, well, this is not very accurate, I find. I'm going to show you my protocol. This is a video. It's, of course, a sped up video. It's between 15 to 20 minutes. I use, of course, well, sometimes you have a hard time bonding on the 7, but it's because of the mouth opener. I really like the mouth opener that I use here because I see that I have a very good field of view. So this is what I do, and then I try. I have a different protocol for the upper arch and the lower arch. So this is the bonding system. And so on the upper arch, I use a jig. It's a and at the lower arch, I split the jig in two. I'm under the impression that it's more successful with it by cutting the jig, and I talked with other clinicians and they do just the same. So for the upper arch you can use the jig as it is, but you cut it in two for the lower arch. So when you get used to that, this is the type of result you have. You do not have any excess resin, you have a very good result, very accurate for tipping. Usually I have a hard time bonding of 35 and 45, but thanks to Indibond I have no problem anymore. A few clinical cases, if you like. I'm not going to really discuss the treatment plan. I'm really here to show you the indirect bonding. This is one of the first cases which I treated with Indibond. This is a class 2. Gummy smile, patient did not want surgery, so full class 2, we have a deep bite and ectopic canines, and we extract 14 and 24. 16 months in, this is what we get. We unbonded the case. Of course, we're waiting for final settling in the posterior segment. I didn't have to finish j'ai plus rien là depuis 15 minutes. So I'm not saying that I'm finishing all my cases like that, but when you start being knowledgeable with the technique, this is the sort of result that you get. The smile is still slightly gummy. She didn't want TARS, but I suppose it would have helped. So those are the arches before and after. The retention system is bonded. It's in PEK. It's very recent. This is another case. The child is 12. Bonding was very accurate. 14 at the upper arch, 18 at the bottom. It's going nicely, but I do see that there has a problem on number 1-3 and number 2-3 tipping. And so you may wonder whether the bonding isn't successful or maybe my plan was not accurate. So I look at my plan, you can see that I did not assess the tipping properly on 1-3 and 2-3. But now that I've learned from my mistake, I'm going to show you how I compensate for that. Another case, this is an ortho surgical case. Cross bites on both sides. Those brackets are diamond brackets. It's just because the practice that I work in Switzerland were working with diamond in the past, so I'm just using up all the diamond brackets that they have in the drawers, but then I will use orthopartner, obviously. So this is a class 2. This is right after disjunction. The patient didn't want surgery. I bonded that case, and after 6 months, 1818, it's leveled and aligned. This is the pan X-ray and the sort of result I got. Now, this is the most important and interesting part of my presentation. This is when I share tips and tricks. So those are the learnings that I harnessed after 2 years of clinical practice. So generally speaking, the first tip that I can give you is to delegate. You've seen it before. You need to invest if you want to use Indibond, but you need to be smart in the way you use your time. This is a software that I use. It's a form of sticky type, so you can have notes directly on your setup. For example, you have the record of this patient. The assistant is going to write a note saying that the setup needs to be validated, because I'm responsible for validating the setup. And then I think it helps very much with follow-up. We work very much with that. We have many users and it's free of charge. So I do recommend that you use this app. You need to control your costs and keep it as low as possible. You can insert your bracket in Office in the jig, because it's going to help you save between 20 and 30 euros per jig, and your assistant can do that in the office. You can also print in your office. This is something that I'm starting. And then you need to delegate. It doesn't matter if your assistant works twice as much as she used to, because her costs, the workforce cost, is less expensive than your own time. I'm going to show you a platform which is going to help you cut your cost. The platform is named OYAHON or Clinic Pilot. You may want to look that up on Google. So you have the entire inventory, so all the brackets that you have the invoices as well. You also can look at the expiry date of your product, and there's also a real-time analysis of the different products. So it directly hook up to platforms, for example, Mega Dental, etc., and it's just benchmarking the costs of the different products. So if you have suppliers with whom you already have a discount, it's going to make sure that the discount is properly applied. So this is for your orders, and you can decide thresholds. So when you are running low on the number of brackets, for example, it automatically triggers an order. Yeah, name of platform is OYAHON, but if I'm not mistaken, now the name is Clinic Pilot. They changed recently. I checked. They changed their name. So it's a yearly license, 1,500 euro for a year. And from what I've seen, with all the savings you make on Mega Dental, for example, you have a very good ROI. A few tips on how you can submit your form. Well, in Switzerland, we do not have the same organization in our practice, and so I have an assistant placing the brackets in the jig, and I have no unbonding on my 7s in Switzerland, and it's exactly the opposite in France, potentially because we select the wrong bracket. I used to select this ceramic bracket Genius 2 from 7 to 7, and apparently if you use that, you have the former tubes that we used to have in the past. And this is why those brackets would come unbonded. So you need to make sure that you have the right bracket in the right tubes. Trimming of jigs. When I started with Indibond, Charlie called me and asked me, well, should we split the jig? I was a young practitioner and I was unsure. I thought that one jig would be fine. But when you look at the website, some clinicians split the jigs in 3 parts. You need to make room for the canines, and the canines are a bit lower. So I just followed that piece of advice. And I thought, well, if we need to compensate for potential lack of accuracy. But so when you split in 3 parts, your jig is just too flexible. And so when you press in the jig, the bracket just is bonded too low towards the gingival margin. Then I decided to compensate. So my piece of advice would be to use a single jig at the upper arch and 2 jigs in the lower arch in order to be more accurate.
For the setup, look at the distance between the bracket and the tooth. The first modification is to bring the brackets closer. Catherine Lasvernias told me that there was a button, but I couldn't find it. I looked at the whole platform, maybe I didn't have access to the right functions. That's the most important. Look at the mistakes made by the AI. Look at the lateral. The median line is not what it should be. It's wrong. And initially I said that some dentists work with Indibond and don't even change the setup. The setup is bad. In 80% of the cases you have to make changes. Once you have removed the line on the right-hand side, the contour, you see that it's not okay. So the type is not easy to confirm because you don't have the patient in front of you. On this one I had a doubt. Sometimes the AI will not, the DIPS AI will not cut the soft tissues properly. We've got Zoom and Netflix. I had a doubt on lateral and I went to see the pictures, except that the picture up front was not good enough and the lateral was taken 90 degree. Now what I do, and I no longer have any mistakes now with DIPS, is that I use the scan, the CBCT, but you don't always have the CBCT, but I use the digital impression. That's the intraoral scan. I know that it's reliable. Here I had a doubt. Here I have a root mesial type on the 12 and I'm going to apply it. I do it systematically. Some mistakes I have noticed and now I no longer have any issues. And as Ariel was saying, it's better with CBCT, but you don't always have the CBCT. Either if you want to do it to all your patients, you should not bill the patients, or you have to justify the billing to the patient. That's also very important. When you change the type of this bracket, look at the matching on the height table. The height doesn't change. It should have. That's a mistake. On the 16 type, we have changed the height of the bonding. The 5th stage in my setup validation is to look at the predicted result. Look at the predicted result to see whether I have intruded or extruded the tooth by changing the type. That's very important. Chair side. Nowadays, we always check visually what the distance is between the brackets and the teeth. The brackets are standardized. They don't always match all the teeth, the anatomy of all the teeth. So we check the distance and we put a line with a felt tip pen. Here we see the distance between the bracket and the tooth. And the last tip, that's something I discovered earlier, not very long ago, for extractions. Lingual, you have to extract after bonding. I extracted before. The teeth didn't move, but the tray was so accurate that I wanted it had 15 and 25. And when I removed the tray, it did not. It was no longer adjusted because 15 and 25 were gone. So extract after bonding, not before. These are the advantages and disadvantages of the solution, pros and cons. On the solution, I'd like to have a sheet, like when you order your cases, you need to have distance between the bracket and the tooth, so you don't have to do it empirically with a little ruler. And stripping. Indibond will tell you how much stripping you need, so that would be nice to have it in writing. And we expect a better natural segmentation of the teeth. As you may have understood, we need to do some retouching to make up for it. That should be improved. Thank you for your attention. Thank you for this beautiful presentation. Any questions? Thank you very much for the presentation. It gives me some tips because I use Indibond as well. I print the trays in office. I like to do that. But I have a question. Sometimes I have issues. Once I remove the tray, I sometimes have bonding agent flash. Is that something that happens to you as well? Do you have flash? And how do you avoid it? Well, for me, it depends on the assistant. It's a very good question. I do have bonding agent flashes. It's better and better when you control the quantity of bonding. I have an assistant who does a good job and the other one doesn't. Once I had to tell the assistant to put less bonding agent, and one of them does it perfectly. Nicolas Silfides came to replace me the other day. He doesn't do indirect bonding, came to my office, he bonded in 37, he bonded top, bottom, not a single debonded bracket, it was perfect. Indibond, you can trust it. In Switzerland, the assistants are allowed to bond. In Switzerland, I let my assistants do the bonding. I have another assistant with a 30-year experience. I say a little less than direct bonding, and it's a catastrophe, it's a disaster. Now she's beginning to get the knack of it, but it's either it's not enough bonding agent and everything comes off, or too much and there is flash. Sometimes I have some flash, but very easy to remove because it's occlusal to the bracket. So a little action with the burr, and that's it. But it's the assistant plays an essential role. There is a distance between the tooth and the bracket, and we don't know how much to bond. 0.3 millimeters, 0.4 millimeters. And if we measure the distance, we know exactly how much bonding agent we need. Elle, ça marche très bien, donc je pense qu'il y a un problème de distance aussi. Non, elle, quand elle a parlé la dame, on entendait beaucoup mieux, je pense qu'il y a une histoire de distance.
Ça, c'est en bas du cabinet, ça, c'est un magasin de perruques. Ça va fermer, heureusement. Pour un Indibond posé, vous avez une perruque.
C'est bizarre quand même, parce qu'on a posé la question, on entendait.